So before lunch, we ended our first case, and I hope that the four of us managed to give you, very quickly give you some of obviously I need a post-lunch nap. I managed to lay out the terrain of this argument and a potential solution to the argument, which I think Catherine showed us at the end. So let's open this up to discussion. What people think about this, because it's an egregious example. There's a solution that's been presented. We know the historical antecedents to it, the tie-in with what we discussed yesterday. And we know that 1 billion people have been left out of this. So what are people's thoughts as we think about this?
And then you're thinking, well, here's the conference talking about that. But I was sitting here feeling it felt like we'd kind of fallen a bit like Alice in Wonderland. Everything was like, everything you think is true, it's like all upside down and all crazy. But
Basil did that to us.
Yeah, but I was thinking about some of the motivations of behavioural change, and I was thinking fear is obviously one of them, and the legal. But what about shame, as a sort of maybe a moral imperative or a moral accountability space, and not a moral accountability to hide, like we've heard with the UN and cholera, and we'll hear later. But shame as a motivation as well as fear. Question mark.
Thank you, Connie, for such. Thank you, sir. I think it is actually the ambulance at the bottom of the cliff, all of it. Thank you so much, Dr. McMillan. I wanted to talk about these standards and practices, and I think it ran through all your presentations, in that this has been happening for such a long time that clearly it's not a situation of we've made a mistake. It's not a situation of it was a tried and tested. It is the construct of the WHO and how they've wanted to control everything. Because at current point, even where we're sitting, when they come up with these guidelines of theirs, these guidelines are connected to funding, right? So, for instance, countries, as much as they want to be more progressive, or we push them to be more progressive, to use the newer drugs, to use the newer diagnostics, they have to follow WHO guideline. They'll say to you, we can't get lamb because it's not a WHO guideline as yet. So sorry, we can't procure lamb. We can't get bedaquiline, it's not in the WHO guidelines. Or once they've actually assented to the guidelines, they don't have guidelines themselves as state guidelines. So that takes a very long time. So this farce of control is, or this whole control element is, I think, a farce, because it is tied to budgets, because weak guideline adherence means you don't have robust TV programming. And a very prevalent example that I can bring to the fore from the SADC region has been what's been happening around Gene Expert and the procurement of Gene Expert machines.
Explain what that is for everyone.
Okay, so Gene Expert is this modular machine. It's basically the newest diagnostic tool that we now have. It's a beautiful computer with a beautiful assay that what happens is you get your results to find out whether or not you're positive, you've got tuberculosis in 2 hours. What used to happen is they used to take your sputum, they had to transport it. It took 2 weeks to a month, but now you can have your results in 2 hours with Gene Expert. The problem is, number one, it is a beautiful high-tech machine. It looks like, what is it called?
Espresso machine.
Yeah, an espresso machine, and it also goes with the laptop. But it requires sterile environments to work, and if you put it anywhere near dust, it breaks. It requires cartridges to work, and those cartridges are about $7 per cartridge, and one cartridge is one test. So a lot of our countries were really excited that we had something else besides, having to wait for sputum and so forth, and we thought it was a very kind of good advancement. The problem is, the machine is so highly sensitive, it doesn't work. So in a lot of our countries, it's being used as a doorstop by the healthcare workers, because even to fix a Gene Expert machine, you need to get expertise all the way from France, right? Not only are you paying $10,000 for this machine and the computer, but if you are in a country that does not have stable electricity, it loses results on the regular. So it's really not a point of care for us, and it doesn't work. But because you will not get money in your TB budget if you do not procure a gene expert or mention that you want a gene expert in your concept note to the Global Fund, you're forced to procure a gene expert. And of course, there's process patent issues there. I'm not going to go into those. I think I'll get in trouble. But so gene expert is just one of those things that I really feel like we are tied. These guidelines are always tied to something, and governments are really confused. Talking about cost effectiveness, we know that this is not a new argument, and it's the cost effectiveness argument is what is a construct of the Universal Declaration of Human Rights, right? That's the problem, because they said that countries must provide the highest standard of health within reasonable means. Of course, if you say within reasonable means, you're giving them a getaway jail card, right? This is why I think this Professor Dave Fiddler mentions this approach, because even in South Africa's constitution, according to section 27(1)b, it says, state to take reasonable legislative and other measures within available resources to achieve progressive realization of the right. Meaning by virtue of that, by virtue of them not having resources, they do not have to give you all of your rights. They do not have to give you comprehensive packages of care. They can just give you limited care, and basically cost effectiveness is always used against us in rights arguments. In terms of solutions, I think Professor Commissioner Dr. Devji's approach could work, because I think I was telling the colleagues at lunch, he mentioned the whole fray between rights and duties. And I think, you know what, let's stop being beggars and talking about our human rights. Let's start talking about duties and see how we can stand on equal footing around those, and use legal arguments that speak more to us being duty bearers. And maybe if we stopped looking at duty as something that is heavy, that's something that weighs you down, but something that can actually give you power, maybe we'll get out of this rut. And I would like to explore arguments around that, and then how we can use that in a lot of our court cases. Talking about WHO and UNAIDS, they really get on my nerves, because now recently again, they've now pushed the Zambian government to mandatorily test people for HIV. You can't have test and treat if you can't put people on drugs. You are telling people that they have no right, but they have to be coercively tested. On top of it, you're going to criminalize them. So they did this. They released the policy. The president made a mistake and said, yes, we are now going to have mandatory testing, and yes, it's going to be compulsory. I was like, okay, fine, forgive him. But anyway, they then released a statement that affirmed what he said. And they said, no, we mentioned it within some sort of protocol, as they always do, to try to justify the mistake that they'd made. But it's such a foregone conclusion, because they've really messed up within Zambia. Now, what we're going to start seeing is that people are going to be forcibly tested. And WHO, can you come up with a retraction? Can you speak to government? No, but we will write another article explaining our position. And that's what they've done. They've washed their hands of it. They've screwed us up again, and they've washed their hands. And I just think it's happening over and over again. And for me, it's really frustrating that it is status quo. It's practice. So how do we take this practice and just squash it? No, not even holding them accountable. Somehow finding a way to ignore them and do our own thing. Because currently, clearly, following them is us just getting ourselves into this consistent fray that I don't see us getting out of. Thank you.
Okay, Mara, and then Mona.
Thanks. So sort of following Dr. Purcell's question, I was wondering if you could say a bit more about what you think is motivating the intransience on the part of WHO to revise these guidelines, because it's not sort of unheard of for them to change guidelines. And so, but it seems like GTB is unwilling to do this. Has there been discussion in the expert meetings or at WHA or at regional meetings? Is it just, you mentioned the experts who sort of just signed the letter saying they're not going to object. Is that just path of least resistance? Are there ways that pressure can be put on those individuals?
Okay. Mona? You have a mic in front of you, yeah.
Hearkening back to your question, there seems to be three kind of ways to get accountability. There's the legal, the financial, and the reputational. At least those are the movers of any particular organization. And I sense from yesterday and today, including your question yesterday, that there's an overemphasis on one form of legal accountability, which is suing them in the national courts, which is probably the least likely to lead to a result. It has other advantages, which is public awareness and being a pain in the ass to the respective organization and forcing them to confront their own actions. But if the objective is justice, that's not where you're going to get it, basically. Within the legal risk category, there's two ways you can influence the decision-making or the change of behavior, which is a beautiful way to think of it, is the European Court of Human Rights, where they have been successful in overcoming even Chapter 7 resolutions of the UN to achieve greater due process, for instance. So I think that is something that we could consider. And especially if you're coming at it from a human rights perspective. But you would need a nexus to Europe, either a citizen who has dual nationality.
Probably have a lawyer like you thinking about this because they've set the cutoff at 100 and most European countries are below 100. Just Turkey's below 100.
Happy to help if I can. Court of Justice and the European Court of Human Rights. But then there's the advisory opinion track, which is in both conventions, the one applicable to the UN and the one applicable to the specialized agencies. Any one of the countries that has victims would have that possibility and could appeal to any of the intergovernmental organs. And that in and of itself is the cheapest way to get public awareness and notoriety within the intergovernmental organs themselves. Even if it fails to lead to a request, it's a huge thing to have it on the agenda. So those are three legal things that one can use that we haven't used. Financial, of course, you can have, as Mara and I were discussing, pressure from donors, any member state that makes a public display of wanting to condition its payment of its regular contributions. So there's different public diplomacy things that can be done to raise awareness and to get the organization to at least respond, if not to act. Letters from lawyers, threatening certain things will at least tie up the resources, both human and financial, of an organization. So, seeking settlements or exposure. And last but not least, the reputational recourse. Vice has done several documentaries on the cholera issue that have, of late, drawn tremendous attention. They're very open. They're incredibly, I would dare say, revolutionary in terms of what they're willing to cover and how on the ground their coverage is. It's really quite beautiful. But there's op-eds, there's wonderful, not enough, unfortunately, journalists who are very much tied to these causes and are very much sympathetic to telling those stories. So we can establish greater networks with those actors who are willing to, speak truth to power, basically.
Okay. Rob and then Mara.
And using this window of opportunity of the new Director General sort of coming into post, who has been campaigning on a ticket of universal health coverage right from the outset. And in fact, he's just been on a tour of the regional committees, and I've been sort of tracing his speeches where he's going on and on and on and about universal health coverage, meaning that everybody gets the health services they need with financial protection. And, with the emphasis being on, high need groups, this would be pretty straightforwardly, obviously, a group that should be getting these services. So I think, sort of maybe to approach the Director General to point out that, these guidelines are fundamentally inconsistent with the whole ethos of universal health coverage, and perhaps give him some time to do something about it, and dare I say it, perhaps not one for the cameras. This, imply that if he doesn't do something about it, that there will be op-eds appearing in the Lancet and the WHO bulletin, just showing. You talk about hoisting by petards. This is some new WHO guidelines that are fundamentally incompatible with universal health coverage. So if you're going to be serious about this agenda, at least get your own house in order first.
Yeah. Mara, you wanted to come back with a thought?
Follow up on what Mona said, also using WHO's own governance mechanisms. So getting Peru, or I don't know if Peru is on the EB at this point, but one of the states on the EB to put it on the agenda for the World Health Assembly, ask the Secretariat to issue sort of a justification or explanation for why the policy is what it is, to reconsider it.
Yeah. So should we just go down the line and we can just comment on these and then we'll go to the next section?
Sure. Okay. Wendy, when you talked about fear being one of the main motivations that lawyers work on, the fear of losing a lot of money, I'm not one of the lawyers that thinks in the end that's going to do all the work. I like that it does some of the work, but it doesn't do it all. And shame is kind of the way that human rights lawyers have worked. It's called name and shame. So that's actually an old way of thinking about it. As Tom and I were sort of talking about this for, I don't know, the 20th time last night, we were sort of thinking about the question that was raised yesterday about, is punishment the way to go? And I'm actually, I'm with Uncle Faisal. I like how you're called Uncle Faisal. That, like, you know, we need to give people a way to do the right thing and leave without humiliation. And that, you know, I also think that you can't have a one size fits all. You have to look at the context, look at the situation, understand what your exhaustion of remedies is. Like, how many things have you tried? Like, you go down a list of things that you do to try to persuade somebody, and if they don't take the positive options, you get increasingly negative with them. So I think you have to be very thoughtful about that. But really, the most important thing that we can do here is not just change these guidelines, which I think Tom will say are going to be changed. I think we know they're going to be changed, but change the mindset that makes us have to fight this fight with every single, you know, new screwed up protocol guideline. And we really need to get people to take seriously at a cultural level what these standards mean. It's not just a legal principle. It's a institutional principle. It needs to be baked in, is what people say.
Thank you. I think the only one that Mara's question about I think it was why this change not happen, or why is it so slow, or what's that?
What's motivating WHO?
Yeah, I don't know. I can't say exactly what's maybe motivating them, but from the history of tuberculosis, that's what I described very briefly, what was going on in the early 1990s, is part of a pattern that then continues for, well, up to the present, of course, but goes all the way back to the beginning of the 20th century in efforts to control tuberculosis outside of, you know, U.S. urban populations, amongst American Indians, amongst Africans, amongst people in South Asia. I mean, it's just part of a century-long pattern of trying to find the cheapest, most efficient way of doing things, and not listening to what people on the ground are saying is or is not working. Having faith in certain interventions and ignoring evidence to the contrary. I mean, none of, as depressing as all of that is, by the time I got to that portion of this book I was working on, none of it was surprising. It just seemed of a piece. That Salmaan mentioned briefly the emergence of drug resistance immediately after antibiotics came on the scene, and it wasn't so much that, you know, in clinical trials people knew it and they developed. I mean, it was that, and they developed a multi-drug regimen. It was that by the time TB work came to Africa, I think, you know, Salmaan, to an extent anyway, underplayed the insistence on isoniazid alone. I mean, that went on for a decade and a half all over East Africa, and resulted in an enormous, intractable, and totally out of control drug-resistant tuberculosis epidemic by the middle of the 1960s, that the WHO refused to do anything about. So to me, it's part of the culture of TB from the beginning that predates the WHO, frankly.
And I think it's linked in with the power question we've been discussing too. If there's two sides of the equation that WHO is looking at when they're considering what are the negative things that could come from any set of decisions. If there's not public pressure for prevention, the even minor risk of side effects or resistance that Salmaan identified, far outweighed, of course, by the risk of getting TB and possibly dying. If that second category is not front and center in anyone's minds during that decision-making process, I don't even know if it's motivation. It might be lack of motivation. It might be the easiest thing to do. Is just say, where are we going to get the most grief based on what we do? If there's nobody yelling at us on this side, but we could get sued over here, or or an NTP director will say, you've been telling us for 30 years to do this, and now, like, just the difficulty of explaining why all of a sudden it's okay. That's why I think even if there's a new guideline, there's been a fog of doubt surrounding prevention that's been going on, similar to what happened with the water question. This false dichotomy between one and the other, you have to do one and not the other. And the questions about if it's safe for people. I think, of course, you see even groups that are already approved by the WHO, very low uptake of IPT among HIV positive people and children, as doctors say, well, this makes me nervous, everything I'm hearing about how we shouldn't do this, despite the data. So for me, I think that's really important. And right after, so I'm not saying this is instrumental, but it was probably a coincidence. But right after the paper last year, I was in Geneva for a Stop TB event, and I was approached by one of the people that has been in the TB department for a long time, and they said, you know, kind of suggesting that they had read the paper, but you know, we're really going to do something about LTBI next year or the year after. And so you wonder what that means. Like, does it change the fact that they're looking at these kind of false choices? Is there not going to be pick the most cost-effective intervention at the cost of all others? Is that approach going? Is it saying all countries can use? Are they going to just delete the lines and get out of the way, as Admay was saying, just get out of their own way? Delete the lines saying don't apply the new science to these places. What's that combination of changes going to look like? The rumor is that there will be one guideline for the entire world, but shouldn't be that exceptional, because that's what they did for HCV. They did it for HCV, they did it for surgical infections and everything else. There's one guideline that has nothing to do with income status. So, but they're talking about that coming out in November. So I guess part of our exercise is how do we make it most likely that there won't be that asymmetrical weight on the scales?
So the other, just to go back to the shaming question, I'm not sure that they can be shamed, because I think you have to be shamed before somebody. Right? Your peers have to say that what you've done is wrong. And I'm struck by one of the scenes that Hannah Arendt writes about in the trial of Eichmann, where they bring his pastor in, and they question him, and they say, did you ever tell him that what was going on was wrong? And the pastor says, no, nobody did. Everyone thought this was okay. And so even till today, I mean, I was just talking to a colleague on Tuesday about this issue, and she said, yeah, person X from USAID just got up at a meeting last week or 2 weeks ago and said, we can't do latent TB treatment in poor countries. They're not able to do it. I was in China a few weeks ago, and we were talking about latent TB with people from their government, and academics there said, oh my God, we can't do it in China. And I said, you're putting a man on the moon in 2020. You're building an island in the South China Sea. You're telling me you can't do active case finding in latent TB? And the crowd actually clapped. They were like, yeah, of course we can, right? But it's so strange that anyone would think that. So, I think that's the problem. There isn't the appropriate of people's peers that stops this. So the idea of shame, I think, is important. What Mara and I were talking about at lunch, and I didn't bring it up, just because it's a talk on its own, but Tom and Mercedes and I, we've been really trying to deal with this question, and we've realized that the legal channels don't work because there's a lot of barriers. People work through committees, and committees have votes, and so you can't sue individuals easily. We've also realized that the donors are part of this. The donors don't want to give money for this because there'll be a lot more money. It's a lot more money. It's a lot more money to treat latent TB. There's 4 times as many people on any given year that have it than have active disease. And so, they're all part of this. And so we realized, we started thinking, what could we do as a strategy to get around it? So we started a movement with the people our friends from the Stop TB partnership and a few others. IRD, one of our partners who works in 15 countries, we started a movement called the Zero TB Initiative. It was it was first called Zero TB Cities and now Zero TB Initiative, and we've asked the question, how can we get around these mechanisms? How can we actually get to the grassroots to do what Faisal was suggesting? Like, how do you actually get that face-to-face type encounter? And we realized, who actually looks at these patients face-to-face? Well, the people that actually deal with them are the grassroots. And so we went to cities. And we went to cities and said, do you want to fix this? Here are the data. Are you interested in fixing it? And surprisingly, cities as big as Chennai and Ho Chi Minh City and other places, people in their government said, yeah, we do. And the Chinese government is now saying, now that we've presented the data to them 3 or 4 times, they're saying, oh my God, this looks like the only path. So they're starting a pilot with 31 cities. So, this now has grown to 46 cities. It's not I mean, it's one of these things that kind of weighs the other side of the scale. We heard from Christian that with the water, one of the biggest fears of the WHO was to not be invited to meetings and to be irrelevant. And I think what we've done is we've created a strategy where we're going directly to people who can work with the grassroots, who have their own resource base, but it almost makes whether these other people change their guidelines irrelevant. Almost, because these countries still need donors, so it's not 100%. But what it does is it's tipping the scale so that these guys now, are saying, oh yeah, we're going to redo our guidelines, because enough cities are saying, oh, we want to do this.
WHO country officers have changed the way they approach that very quickly after enough meetings with the municipal corporations and the mayors of municipalities. And these are cities of 10 million people. They're very, very consequential discussions that are happening, and things have changed very quickly.
Yeah, so I think there is some level of hope if we come at it the strategic. And I'm not saying that suing people and working through UN mechanisms shouldn't be done. I think all of it should be done, because this is a mindset that needs to change. But at least this is one way to do it also. Kenyan, and then Majid.
Yeah, so one of the things that, just thinking about the sort of WHO guidelines, in relationship to, high-income countries, and, we're not even doing that in the United States, right? So
Latent TB.
Latent TB, yeah. First of all, we don't have a new set of guidelines.
The guidelines from the late 1980s and early 1990s say to do it.
Right, but we
don't do it. Some of them,
but we don't have. Yes, but the CDC has not released the updated guidelines for the short course treatment that we've been waiting for the last several years.
For rifapentine, you mean?
Yeah. So there's some reasons for that I won't get into, but so that's true. The other thing in the U.S. is LTBI is not a reportable public health condition. So therefore, when you look at the financing, the way CDC calculates their budget for Congress to submit to Congress every year for what funds they need for the Department of Tuberculosis Elimination, we're only counting the 9,500 active TB cases in the United States a year. We're not counting the 13 million estimated, LTBI cases, which the TB programs at the state and city level still have to, they're still, if they find an active case, they're still doing the contact tracing and all of that other labor that just has no budget, right? And this has been something I've actually been pushing, first of all, and within that context, we finally have gotten to a point that CDC seems to be now interested in trying to get the U.S. Public Preventive Task Force to make LTBI a reportable condition.
What do you recommend treating it? It's just not reportable.
Yeah, it's not reportable, but once but there's a kind of a policy thing, because once it's reportable, it kicks in all these other sort of automatic mechanisms for how it has to sort of be dealt with. There has to be funding. It becomes a part of the funding formulary, so it actually does matter that it's counted in that way. In terms of being able to really build out a public, an infrastructure to deal with it. So just think about that. And also just, from the kind of advocacy community, I've also just been pushing in the 4 years I've been working on TB, why are we going to the Hill and telling congressional members, when we're talking about domestic or global TB, but specifically on domestic, because that's kind of, they'll respond to the domestic before the global in many cases. If you say 10,000 cases, if you said that to me about anything, in a country of 300 million people, I'd shut the door and be like, I don't care. But, but if you're talking about 13 million people, that's a different conversation. And so I also just wonder about how you all feel about this question of kind of moving the language from, latent TB to TB infection versus TB disease. So that's what we've done.
We try not, I know I used latent TB here because I'm brought up in the old school, but really in all of our things that we're writing, we're calling it TB infection for this very reason, because there's actually a lot of data now that suggests that people with the infection are not latent at all. The bugs are quite active in them. They're just not demonstrating what appears to be active disease. So you're very right. This issue, think about the language. When the WHO declared their emergency in 2003, one of the reasons they gave is that 2 billion people are infected. Then they proceeded to do nothing about it because it was going to be expensive. But it's, the fact that so many people are infected and that 10% of them are going to get active disease is alarming. That's why they raised the alarm. That was part of their argument for raising the alarm. But I think what has happened, and Tom and I face this all the time. We go to cities, they're like, "Oh my God, we love this idea of treating latent TB and active TB. We want to do exactly what Comstock has done. Is this going to cost more?" And we're like, "Yeah, of course it's going to cost more. Like every household's got 4 people that need this, so you're gonna 2 to 4 people, so it's going to cost 2 to 4 times, and you have to deliver the care, and you have to buy these medicines." And
But over a timeline.
over a timeline, but then your disease rate drops rather than staying the same. So we tell them you can spend $1 million from now till eternity, or you can put a little bit more in now and it's going to drop really steeply, like everywhere else that this is done. And I think there are some places that are saying, yeah, we're going to do it, but it's places that have their own money. Because the WHO, you have to follow their guidelines. So we have colleagues who work in Pakistan right now. They have $40 million to do TB treatment. They wanted to do latent TB. They said, we want Karachi to be a zero TB city. The Global Fund said, unfortunately, we have to follow WHO guidelines. And they don't say to do this, we're going to ask their permission. And WHO said no. Then there was a big fight back and forth, and they allowed a small pilot in one part of Karachi. So it's got to be a country like China or a city like Chennai who's got their own money, and they're like, you know what, we're doing it.
Just to build on that, great point. And we definitely don't want to create some fantasy about the U.S. TB system being perfect, and I want to make sure that I don't leave that impression. Even with the case of New York City, there were lawsuits. There was public pressure to initiate the treatment in the first place, which you may not often hear in hagiographies of certain people. So I think it's important to realize that there's a fight every time. For us, it's just it's a question of emphasis and the burden. But I will say, in North Carolina where I live, I've gone to some local cities, I won't name them, gone to their county health departments and actually witnessed some really horrific turning down of people say, there's an active TB case in my family, can I get screened? I should be on preventive care, I think. And I've witnessed the person say, go talk to your PCP. And they're an immigrant, they don't have a provider. And they say, what? And then they say, we don't have an x-ray here. Go find an x-ray machine and then we can see if we can help you. So like what you're saying, totally different category of treatment. That has to be fixed too. I was hoping there would be more cities in the US that could ally kind of sister city kind of projects, but they have so much work that needs to be done.
Okay, Majid, you get the last comment, and then we'll move on.
I was interested to share my experience with you, like you just talk about the grassroots level. Yes, this can be sought out by indulging those people who really work at grassroots level. In 2013, I was conducting part of a research team that was funded by ASAID in one of the remote area of Pakistan on a role of community spaces for the promotion of health there. And then second time in 2016 whole year, I conducted my own research negotiating tuberculosis in Pakistan. In both of the cases, when I went to the very grassroots level, I got to know that there is a lady that is lady health worker titled by the government. She is supposed to visit 200 to 250 household in a month. That is the target. And I guess this is the lady who is having all of the household data, number of kids, their age, month, and how many people are in a household, everything she knows. If we give, I conducted some of the interviews, but they were not updated on the causes of the symptoms of TB. That is a reality. And there were so many social stigmas that I was not expecting to hear from them, but they were sharing me all those social stigmas that are attached to TB. And I think so if we get themselves involved and we share and we decrease their burden of household, like from 250 to 200 or 200 to 170, and we get some, we induct some more lady health workers, and they are having some close contact to every household, every individual. And we do provide some sort of basic training to them. Although they will not treat the patients, I'm sure, but on finding some of the symptoms, they can push them, they can send them to the TB treatment centers. Thank you.
Thanks, Majid. So, I mean, I think this raises a good point. From the fields of Pakistan, you're saying mechanisms exist. The policy isn't there. And I think what we want to see, and I think we would learn that from what the HIV community has generally done, which is that you really have the demand coming from communities for certain things. And right now, you can take a TB patient aside, they won't know what medicines they're on. there's no treatment literacy. So this Zero TB initiative, we're really trying to address every single one of these things. Ruvandi is going to be working with us to work on LTBI guidelines. We've decided to make our own guidelines for Zero TB cities, so for the cities to use. We'll also have guidelines on treating kids. We'll also have guidelines on treating drug-resistant TB. And it's one approach. This is just one of these social strategies. We Tom and I, we tried working through the UN system. Probably I spent 5 years going to Geneva, weekly almost, or monthly, and monthly, not weekly, sorry, monthly. And Tom and I, tried to create different systems within it. It wasn't successful, so we thought, let's build something outside. I don't know if you can do this with every disease. You're not going to build a new IMF or something like that, but you are, or maybe you can. but it's certainly, this is, for this disease, this is one step, and I think it's got to be part of a strategy as Roger's brought up. So let's end the conversation here, because I think this is going to segue nicely to the next two cases.